Chapter 46 Upper GI Problems. As a basic pathophysiology, stimuli from the GI tract, kidneys, heart, or brain send impulses via efferent pathways to receptors within the medulla. These are worked to initiate vomiting reflex, a complex act involving several structures. Chemoreceptor trigger zone within the brainstem responds to the stimuli from drugs, toxins, and motion and activates the sympathetic nervous system, causing tachycardia, tachypnea, and diaphoresis, as well as activating the peripheral nervous system, which works to relax, increase gastric motility, and increase saliva. In our case study, JF, a young woman, calls a triage hotline saying she's had severe nausea for the past 6 hours. She denies any emesis, but is unable to obtain any relief from her nausea. JF calls back to report that she's now vomiting. She states she has vomited twice in the past 30 minutes. JF also reports feeling dizzy, lightheaded, and weak. You recommend that she should go to the ED to be seen. She arrives there, and a viral infection of the GI tract is diagnosed. The goal is to identify and treat the underlying cause. Drugs to be considered could be a lot of things, such as anticholinergics, antihistamines, cannabinoids, and corticosteroids, just to name a few. For subjective data, would include important health information such as past health history, medications, surgeries, or other treatments. It may also assess their functional health patterns such as nutrition, metabolic activity, exercise, and their perceptual as well as coping and stress tolerance. For our objective data would include not only a general survey, but along with an integumentary, GI, urinary, and other diagnostic findings. We need to identify the source, timing, and characteristics of the emesis. Did it include partially digested gastric outlet obstruction or delayed gastric emptying? Did it have a fecal odor along with bile? The bile would be a result of an obstruction below the ampulla of Vater. Is there bright red blood present indicating an active bleed? Or was it more coffee ground emesis indicating digested blood? The goals, with minimal or no nausea and vomiting, have restoring normal electrolyte and hydration status, and a return to the normal patterns of fluid balance and nutrient intake. These patients are going to initially be NPO, along with IV fluids, an NG tube if a blockage is identified, carefully monitoring their I's and O's and vital signs, and watching for dehydration, along with psychosocial and environmental comfort. And don't forget aspiration precautions as well. These patients will be on IV fluids until they can tolerate oral intake. Clear liquids and sips of water every 15 to 20 minutes. They can then progress to a high carb, low fat, bland diet. We want to avoid overdistension and call in for a dietary consult as needed. We want to provide patient and caregiver education related to managing and preventing nausea and vomiting, maintaining their fluid and nutritional intake, dealing with any environmental comfort, avoiding sudden position changes, as well as hygiene between episodes. Notify the provider if they suspect medication is the cause, and also consider interventions such as acupressure, acupuncture, along with ginger or peppermint. Back to our case study, JF is given a prochlorperazine suppository and IV hydration at the ED. She reports relief of all symptoms and is discharged to home with a prescription for oral prochlorperazine for PRN use. For gerontologic considerations, our outcomes would include minimal or no nausea and vomiting, maintaining their electrolytes within normal limits, and maintaining adequate fluid and nutrient intake. Also, we want careful monitoring with fluid loss and rehydration. Aspiration precautions are going to be key to protect that airway, and antiemetic drugs, though they do have CNS effects such as confusion and falls. When dealing with oral inflammation and infections, we want to identify the cause, eliminate the infection, help to provide for the patient's comfort while maintaining nutrition as well as hygiene and dental care. Oral cancer. There could be many different types, from cancer of the oral cavity to the oropharyngeal cancers. Head and neck squamous cell carcinomas. They all have an etiology and pathophysiology that's unknown, but does have predisposing factors, such as tobacco, alcohol, sun exposure, pipe stem or other irritation, along with HPV and other STDs. Clinical manifestations could include a chronic sore throat, mouth, voice changes, ulcers, dysphagia, slurred speech, increased salivation, toothache, or earache. Leukoplakia, which are precancerous lesions due to smoking, become hyperkeratosis. It could also be erythroplakia, which are precancerous lesions that often progress to squamous cell cancer. For these patients, we want a careful history and physical, and will most likely need a biopsy or an oral exfoliative cytology, a scraping. For surgical care, they may use minimally invasive robotic surgeries, or radical, such as a partial mandibulectomy, hemiglossectomy, a glossectomy, a resection of the buccal mucosa and floor of the mouth, or a radical neck dissection. Or non surgical interventions could be considered, such as radiation or chemotherapy. Our subjective information would include a past health history, medications, and surgery or other treatments, along with their functional health patterns. While our objective data would focus on integumentary, gastrointestinal, and other diagnostic findings. Nursing diagnoses may include impaired nutritional intake, acute pain, and anxiety, with goals to maintain a patent airway, make sure the patient is able to communicate, provide adequate nutrition for wound healing, and relief of pain and discomfort. For health promotion is going to include good oral hygiene, smoking cessation, early detection, and evaluating for no respiratory complications, ensuring the patient is able to communicate and able to maintain adequate nutrition. Esophageal disorders. We've all heard of GERD. This is a chronic syndrome of mucosal damage due to the reflux of stomach acid into the lower esophagus. For our case study, MC, a 20-year-old man, reports a loss of appetite and occasional lower sternal chest pain 30 to 60 minutes after meals. He says symptoms began about 6 months ago. MC is 5 foot 10 inches tall and weighs 190 pounds. He states he smokes 2 packs of cigarettes a week. Besides chest pain after meals, MC says he has heartburn several times a week and occasionally brings up a bitter liquid into his mouth. MC also has a history of asthma. He states he has needed his inhaler more than usual. Heartburn is a most common complication, with burning, tight sensation under the lower sternum that spreads into the throat or jaw, mimicking angina but relieved with antacids. Dyspepsia, on the other hand, is pain or discomfort within the upper abdomen. Regurgitation, the hot, bitter, or sour liquid that comes up into the mouth or throat, and respiratory issues, including wheezing, coughing, dyspnea, nighttime disturbances, hoarseness, sore throat, lump in throat, choking, and increased saliva. Esophagitis is ulcerations that may lead to scar tissue, stricture, and dysphagia. In the case of Barrett's esophagus, this is metaplasia of cells that increases the risk for cancer. Respiratory problems would include a cough or bronchospasm, a laryngospasm, cricopharyngeal spasm, or aspiration into the respiratory system, leading to asthma, chronic bronchitis, or pneumonia. This would be in addition to dental erosion from the stomach acid. Our diagnostic studies would be determined by their response to behavioral and drug therapies, including a history and physical exam, upper GI endoscopy with a biopsy or cytology analysis, esophagram, motility studies, pH monitoring, among other things. MC is scheduled for endoscopy to evaluate his symptoms. The results indicate he has acute esophagitis as well as Barrett's esophagus. Patient and caregiver teaching would include a low-fat diet with small meals, avoiding alcohol, caffeine, and smoking, maintaining an upright position 2 to 3 hours after meals, as well as avoiding tight clothing at the waist or bending over after eating. Avoid eating 3 hours before bed and keep the head of the bed increased 4 to 6 inches on blocks, as well as focusing on weight reduction. MC is being discharged today. He expresses concern about what lifestyle changes may be necessary to prevent recurrences or complications. Drug therapy would focus on decreasing the volume and acidity of the reflux, increasing esophageal clearance, and protecting the esophageal mucosa. Proton pump inhibitors would work to decrease the hydrochloric acid secretion and irritation. It's most effective for healing esophagitis as well as decreasing the incidence of strictures. On the other hand, H2 receptor blockers decrease hydrochloric acid secretion and irritation. They have an onset of 1 hour and a duration of up to 12 hours. The available forms include oral, IV, and combined with an antacid. Antacids neutralize acid, as well as providing quick relief for mild, intermittent symptoms for a short duration. Take 1 to 3 hours after meals and at bedtime. MC is prescribed Nexium and Zantac as take-home meds. While there is no specific diet, avoiding milk and eating before bedtime can help. Encourage the patient to eat small meals and fluids between meals, as well as, again, weight reduction. There are certain surgeries that may be effective, including anti-reflux surgery that reduces reflux and enhances the lower esophageal sphincter function in those with complications or persistent symptoms. Nissen or Toupet fundoplications are laparoscopic surgeries, and there may even be considered a Lynx reflux management system. This is a ring of titanium beads with magnets implanted in the lower esophageal sphincter to prevent reflux. Here we have a diagram just showing how that Nissen fundoplication is accomplished. MC has repeated exacerbations of esophagitis despite maintaining his medication regimen and diet. His doctor refers him to a surgeon for evaluation. The surgeon recommends a Nissen fundoplication. Endoscopic therapy may include endoscopic mucosal resection or a radiofrequency ablation that uses heat energy to create lesions to thicken the lower esophageal sphincter. MC's surgery was done laparoscopically. He has progressed to a soft diet and is able to ambulate independently. He's being discharged to home today. Hiatal hernias. This is a herniation of part of the stomach into the esophagus through an opening in the diaphragm, also called diaphragmatic or esophageal hernias. There are two types, a sliding that's the most common, or a paraesophageal or rolling hiatus hernia. Less common, though much more cause for concern. Here we just have a diagram of those two types. On A on the left, we have a sliding hiatal hernia, and in B we have a rolling or paraesophageal hernia. The etiology would include a structural weakened muscle within the diaphragm, as well as esophagogastric opening, as well as increased intra-abdominal pressure. Clinical manifestations would be similar to GERD, with heartburn, dyspepsia, regurgitation, respiratory symptoms, and chest pain being common. Our diagnostic studies would again be similar to GERD, including a barium swallow or endoscopy. Nursing care would include conservative interventions such as reducing intra-abdominal pressure, as well as surgical interventions. The incidence increases with age, and concerns with drugs, including decreasing the lower esophageal sphincter pressure. The first sign may be severe esophageal bleeding or aspiration. Esophageal cancer. Esophageal cancer is uncommon, though rates are increasing in the United States. 19% have a 5-year survival rate, and those aged 65 to 75 years, and is more common in men. The etiology is unknown, though the risk factors include smoking, alcohol, obesity, and injury to the esophageal mucosa. The clinical manifestations would include pain with swallowing, substernal epigastric or back pain that radiates to the neck, ears, jaw, and shoulders. They may also incur weight loss, regurgitation, or hemorrhage and perforation. Our diagnostic studies would include endoscopic biopsies or barium swallows, with interprofessional collaboration including being dependent on the location and stage, multimodal approach with surgery, endoscopic ablation, chemotherapy, and radiation all being considered. Surgical therapy may include a esophagectomy, with endoscopic therapy including photodynamic therapy, endoscopic mucosal resections, and radiofrequency ablation. Radiation therapy may be done with chemotherapy before surgery or as palliation. Chemotherapy may be used with a combination of many different drugs, and targeted therapy that can target the HER2 protein or angiogenesis inhibitors. Our nursing assessment would include assessing for a history of GERD, hiatal hernia, achalasia, tobacco or alcohol use. We also want to assess for progressive dysphagia, adenophagia, pain, choking, heartburn, hoarseness, cough, anorexia, weight loss, or regurgitation. Our planning goals would include relief of symptoms, including pain and dysphagia, maintaining optimal nutrition, and improving their quality of life appropriate to the stage of disease and prognosis. For health promotion, we want to teach the patient with esophageal conditions to have regular follow-up visits and report dysphagia. Teach the patient to reduce risk factors and maintain good oral hygiene with a healthy diet. Our preoperative care would include emotional and physical support, general preoperative care and teaching, assessing their nutritional status and encouraging high-calorie, high-protein intake, maintaining oral care, and teaching the general post-procedure care, along with pain management and any tubes, lines, or drains that may be necessary. Postoperatively, the patient may be in ICU for 1 to 2 days to monitor for dysrhythmias. We also want to monitor for complications, an NG tube that will be present for 5 to 7 days, a chest tube if necessary, and focusing on preventing respiratory complications, turning and repositioning, cough and deep breathing, and incentive spirometry. For ambulatory care, they're going to have long-term follow-up, including additional therapies, maintaining nutrition, and counseling related to the prognosis. Let's talk about other esophageal disorders. Eosinophilic esophagitis. This is swelling of the esophagus due to the infiltration of eosinophils. It's usually indicated with a person of personal or family history of allergies and food triggers such as milk, eggs, wheat, rye, and beef. Our diagnostic studies would include endoscopy with biopsy and allergy testing, and a treatment to avoid the known identified food allergens or any other triggers. An esophageal diverticula. This is a sac-like outpouching of one or more layers. There are 3 main areas, one above the upper esophageal sphincter, a Zenker diverticulum, a near esophageal midpoint, a traction diverticulum, or above the lower esophageal sphincter, epiphrenic diverticulum. Here we have a diagram just showing the 3 common locations of those diverticula. Esophageal strictures. These are a narrowing of the esophagus, most often from GERD. Manifestations include dysphagia, regurgitation, and weight loss, and a treatment that aims to dilation of balloons using endoscopy or fluoroscopy, and possibly even surgical excision in extreme cases. Achalasia. This is absent peristalsis in the lower 2/3 of the esophagus. The etiology is unknown, though it does have a pathophysiology of increased lower esophageal sphincter pressure with incomplete relaxation that may cause obstruction near the diaphragm. On the left, we have an early indication of esophageal achalasia, while on the right, it has further progressed. Diagnostic studies would again be barium swallows or endoscopy, with our treatment goals to relieve the dysphagia and regurgitation, improve esophageal emptying by disrupting the lower esophageal sphincter, and preventing the development of a megaesophagus. Here we have a pneumatic dilation to treat achalasia, where they are inflating a balloon to open up that closed-off esophageal section. Other treatments might include a botulinum toxin injection, nitrates, or calcium channel blockers to relax the smooth muscle. Disorders of the stomach and upper small intestine. Peptic ulcer disease is an erosion of the GI mucosa from hydrochloric acid and pepsin. Susceptible areas of the GI tract include the lower esophagus, stomach, duodenum, and post-op gastrojejunal anastomosis. Types would be acute, which is a superficial erosion with minimal inflammation, or chronic, where the erosion of the muscular wall with formation of fibrous tissue. Gastric ulcers are more prevalent in females older than 50. They also come with an increased obstruction and risk factors including the Helicobacter pylori, NSAIDs, or bile reflux. Duodenal ulcers, with a measurement of 1 to 2 centimeters, are prevalent in those aged 35 to 45, and again have an etiology of Helicobacter pylori bacterium. Also come with high hydrochloric acid secretions, and on high risk with patients with COPD, cirrhosis, pancreatitis, hyperparathyroidism, and a Zollinger-Ellison syndrome. Here we have a picture of a peptic ulcer developing within a stomach. Risk factors include things like the H. pylori bacterium, transmission through the fecal-oral route, or medication-induced, such as with the use of NSAIDs. Also, lifestyle factors like alcohol, smoking, and caffeine could also play a role. Clinical manifestations include epigastric discomfort 1 to 2 hours after a meal, burning or gaseous pain. Food may worsen these symptoms. It may be diagnosed with an endoscopy or direct visualization of the ulcer, or non-invasive H. pylori serology tests, or stool and breath tests. Other tests may be a barium contrast, a high fasting serum gastrin levels, or secretin stimulation. It may be interprofessionally managed with goals to decrease the gastric acidity and enhance the mucosal defense mechanisms. They may also initiate drug therapy to reduce that gastric acid secretion with the form of PPIs, eliminate the H. pylori with the form of antibiotics in combination with a proton pump inhibitor, and patient education about adherence and teaching the importance about taking the drugs and maintaining the regimen. Proton pump inhibitors are often more effective than H2 receptor blockers. As previously noted, they're used with antibiotics to treat that H. pylori bacterium. Adjunct drugs to go along with this may include antacids, misoprostol, tricyclic antidepressants, or anticholinergics. Also, nutritional therapy, including avoiding foods that cause distress or irritation, while abstaining from caffeine and alcohol. There could be three major complications: hemorrhage, perforation, or gastric outlet obstruction. In the case of a hemorrhage, this is most common, though a perforation is considered the most lethal. A perforation, if left untreated, results in bacterial peritonitis that occurs within 6 to 12 hours. You would have an immediate focus to stop the spillage and restore the patient's blood volume. They're going to be on a nasal gastric tube for aspiration and gastric decompression, IV fluids and blood, and may also be considering a central line, a PA catheter, ECG, and urinary catheter. In the case of a gastric outlet obstruction, the stomach fills and dilates, causing discomfort and pain that's worse at the end of the day, and they may appear visibly dilated. Belching and vomiting may also provide some relief, though constipation and anorexia will also be common. The subjective data would include getting that important health information like a past health history, medications, and previous abdominal surgeries or other treatments. Also, assessing their functional health patterns, such as nutrition, elimination, cognition, and their coping stress tolerance. For our objective data, we're again going to start with a general assessment, focusing on the GI tract, as well as diagnostic and laboratory findings. There could be many nursing diagnoses to be used here, ranging from acute pain, lack of knowledge, and nausea, and planned goals being to adhere to their prescribed regimen, reduced or absent discomfort, no signs of GI complications, complete healing, and lifestyle modifications to prevent recurrence. Our health promotion may include patients at risk being placed on ulcerogenic drugs, and teaching them to report gastric distress symptoms to their provider. Acute care, we would immediately put these patients in MPO, consider an NG tube, IV fluids, vital signs, and monitor for shock. The gastric content analysis would be to check that pH, blood, or bile, monitor labs closely, and manage any pain and anxiety. In the case of a hemorrhage, we're again going to monitor vital signs closely, as well as using an NG to aspirate. In the case of a perforation, notify that provider immediately, frequent vital signs, no oral or NG intake, IV fluids, pain management, and antibiotics to prevent peritonitis. In the case of a gastric outlet obstruction, we're again put that NG tube into suction, irrigate per policy while monitoring eyes and nose, repositioning the patient, providing IV fluids and replacing electrolytes. For gastric residual loss, if it's less than 200 milliliters after clamped after 8 to 12 hours, the patient can then begin oral intake and eventually progress to solid foods. We want to focus on preventing recurrence and complications, with things like including dietary modifications, lifestyle modifications, medication adherence, stress management, and disease management and follow-up care. Our outcomes would include pain controlled without analgesia, the patient verbalizing their understanding of the treatment plan, the patient being committed to self-care as well as disease management and free of complications. For gerontologic considerations, the patient would have increased morbidity and mortality. The frequent use of NSAIDs for arthritis could also be a major precipitating factor. The first symptom may be a GI bleed or a decreased hematocrit, and the treatment plan is similar with an emphasis on teaching and prevention. Let's talk stomach cancer. Stomach or gastric cancer is an adenocarcinoma of the stomach wall that has increased incidence in the United States, especially within the proximal gastric and gastroesophageal junction. It also occurs more frequently in men than women at a 2 to 1 rate. The average age of occurrence is at 68, though is often metastasized when diagnosed. The 5-year survival rate, if confined to the stomach, is high at 71%, while the 5-year survival rate with metastasis is down to 31%. There are no known specific causes, though H. pylori, autoimmune-related inflammation, and repeated exposure to irritants could all play a role. Other associated and predisposing factors include dietary issues, like eating a lot of smoked foods, salted fish, meat, and pickled vegetables, that H. pylori infection at an early age, lymphoma of stomach, atrophic gastritis, pernicious anemia, and polyps, as well as smoking and obesity, all could also play a role. It would often manifest as unexplained weight loss, indigestion, and abdominal discomfort and pain. The patient may also be anemic and appear pale, weak, fatigued, dizzy, with short of breath. A metastasis or late sign would be supraclavicular lymph node enlargement or ascites. We would get an accurate history and physical, an upper GI endoscopy with biopsy, a laparoscopy, and labs including a CBC, liver enzymes, amylase, and tumor markers. We would also check the stool for occult blood. Surgical therapy is often the best treatment, especially in the case of lesions in the antum or pylorus, as well as lesions within the fundus. Chemotherapy and radiation therapy could be combined, and it may be given intraperitoneal for metastasis. Radiation may also be done with chemotherapy or as a palliative treatment for obstructions or to reduce the tumor mass. Our subjective data would include a past health history, medications, and surgeries or other treatment, as well as their functional health patterns, including their health perception, nutrition, and elimination patterns. Much like the others, our objective data is going to include a general assessment with a focus on the GI tract and diagnostic findings. Our nursing diagnoses would include impaired nutritional intake, impaired nutritional status, acute pain, and anxiety. Our goals would include minimizing discomfort, providing optimal nutritional status, and maintaining a degree of spiritual and psychological well-being appropriate for the disease state. For nursing implementation, we're going to provide health promotion to identify the patients most at risk and recognize symptoms as well as unrelieved peptic ulcer disease. For acute care, again, emotional support, nutritional support, fluid volume restoration, packed red blood cells in the case of significant blood loss, preoperative and postoperative teaching, and chemotherapy combined or possibly combined with radiation therapy. For ambulatory care would be home health care as well as resources within the community. We're going to evaluate based on minimal to no discomfort, pain, or nausea, that optimal nutritional status, and maintaining a degree of psychologic well-being appropriate to the disease state. In the form of gastric surgeries, it could take many different types, from partial gastrectomies, a total gastrectomy where they remove the entire stomach, a vagotomy, a total or selective, where they sever the vagus nerve that results in decreased gastric acid secretion, or a pyloroplasty, that's an enlargement of the pyloric sphincter. Here we have diagrams showing a Billroth 1 and a Billroth 2 procedure. That is a gastric resection with a gastrojejunostomy anastomosis. And then here we have a total gastrectomy for stomach cancer. A on the left is a normal anatomic structure of the stomach, and B would be the removal of that stomach. Now C is the anastomosis of the esophagus with the jejunum. For postoperative complications, we need to be on the lookout for dumping syndrome. This is where gastric chyme enters the small intestine as large hypertonic bolus. That pulls fluid into the bowel lumen, causing decreased plasma volume, distension of the bowel lumen, and a rapid transit within 15 to 30 minutes of eating. It may also result in weakness, sweating, palpitations, dizziness, cramping, borborygmi, and a defecation urge. Postprandial hypoglycemia, which is a variant of dumping syndrome. This results in uncontrolled high carbohydrate bolus that enters the small intestine, causing excess insulin and resulting in hypoglycemia that could occur within 2 hours after eating. Bile reflux gastritis after reconstruction or removal of the pylorus. In this case, bile reflux causes damage to the gastric mucosa, the chronic gastritis, and peptic ulcer disease. For preoperative care, we're going to teach the patient about the procedure and postoperative expectations, including comfort measures and pain management, along with cough and deep breathing, NG tubes, and IV fluid. Postoperative care would include fluid and electrolyte balance, with IV fluids to oral, progressing eventually to solid fluids. We're going to monitor the eyes and nose along with the daily weight and work to prevent respiratory complications. Other post-op care would include monitoring vital signs, preventing infection, and assessing the wound carefully. An NG tube, again, would be used for decompression. It reduces the pressure to the suture line and also decreases edema and inflammation. We want to observe closely for gastric aspirate, including the color, amount, and odor. Also, any bloody drainage that is expected for 2 to 3 hours after. Report excess production, though. For our nutritional therapy, we want to understand the surgical procedure and the anatomic changes, provide for a dietary consult, and reinforce those instructions. The patient may receive either enteral feedings or parenteral nutrition. For wound healing, we want that diet rich in potassium, vitamins C, D, and K, as well as our B complex vitamins. In the case of pernicious anemia, or that is results from the loss of intrinsic factors within the GI tract, and those are needed for the absorption of cobalamin in the terminal ileum and is essential for red blood cell production. The reduced stomach size means there is reduced meal size. For the first few weeks, the patient's going to be provided with a soft, bland, low fiber, high complex carbohydrates, and high protein diet. And we're going to provide these in small, frequent meals. There will also be no fluids with meals. Make sure the patient chews thoroughly to reduce the work on that stomach. And also make sure to things like avoiding simple sugars, lactose, and fried foods. We want their meals to count. We want them to be as high calorie and nutritious as we can. For our patient caregiver education, it's going to relate to things like pain management, wound care, nutrition, and the fact that they may need skilled care or home care services. Gastritis. Gastritis is an inflammation of the gastric mucosa and could occur as either acute or chronic. It has an etiology of a breakdown in the gastric mucosal barrier that allows hydrochloric acid and pepsin to diffuse back into the mucosa. This results in tissue edema, disruption of the capillary walls with a loss of plasma into that gastric lumen, as well as possible hemorrhage. Gastritis could have many different causes, one being drug-related in the use of NSAIDs, females, age over 60, a history of peptic ulcer disease, and anticoagulant therapy. This can be further exacerbated by diet, including alcohol use and eating a lot of spicy, irritating foods. It could be caused by things like, again, H. pylori or other bacterial, viral, or fungal infections, environmental exposure in the form of radiation or smoking, and diseases such as autoimmune gastritis, burns, Crohn's disease, hiatal hernias, physiologic stress, bile reflux, renal failure, sepsis, or shock. Acute clinical manifestations could include anorexia, nausea and vomiting, epigastric tenderness, hemorrhage, while the chronic symptoms would be similar to acute, though possibly asymptomatic and include pernicious anemia. Gastritis would be diagnosed based on its symptoms, as well as a history of drug or alcohol use, an endoscopy with biopsy, H. pylori testing, CBCs, stool for occult blood, and any antibodies to parietal cells, along with intrinsic factors. For acute gastritis, we want to identify the cause and either eliminate, prevent, or work to avoid it. We want to provide supportive care in the form of rest, making the patient MPO, and providing IV fluids while we monitor for signs of dehydration. In severe cases, an NG tube may be placed to monitor for bleeding, as well as to lavage and empty the stomach. Keep in mind there is a risk for hemorrhage, and these patients also may be placed on drugs such as proton pump inhibitors or H2 receptor blockers. For chronic gastritis, we again want to evaluate and eliminate the cause, as well as provide antibiotics in the case of H. pylori, and providing cobalamin to treat the pernicious anemia. Also, make sure we're encouraging lifestyle modifications, including no smoking, and eating 6 small meals a day of non-irritating foods. Upper GI bleeding. In the case of upper GI bleeds, we want to look closely for hematemesis or bloody vomits. They could take two different forms, bright red or coffee ground, and these would be the partially digested blood that has come in contact with the hydrochloric acid of the stomach. The patient may also have melena or black tarry stools from this upper GI bleed. They also may have occult blood, which we would identify with guaiac tests that work to detect blood within the gastric secretions, vomitus, or stool. They come from many different sources within the stomach and duodenum. First would be, again, peptic ulcer disease, resulting from H. pylori or NSAIDs being the most common. They could also be stress-related mucosal disease. We could work to identify the source with an endoscopy or angiography. Also going to be drawing a lot of labs, including CBC with hemoglobin and hematocrit, getting that BUN, so the GI tract bacteria break down proteins, and other serum electrolytes, PT, PTT, liver enzymes, ABGs, and again, that occult blood looking within the vomitus and stool. In the case of a massive GI bleed, this would be greater than 1,500 milliliters of blood loss, with 25% of the intravascular volume, and 80 to 85% stop spontaneously. We want to assess for shock, including tachycardia, weak pulse, hypotension, cool extremities, prolonged capillary refill, and apprehension. In the case of emergency assessment and management, we're going to use careful hemodynamic monitoring, providing for oxygen, and assessing for perforation and peritonitis, including watching for a tense, rigid abdomen, monitoring bowel sounds. Also, make sure we're administering IV fluids, as well as blood and blood product transfusions as needed. Endoscopic therapy is a first-line management that should be provided within 24 hours to determine the course of treatment and the need for surgery. Once that site is identified, surgery may be required. They could also require more than 2,000 milliliters of blood for shock. We're also, again, going to be providing for proton pump inhibitors and antacids. For our nursing assessment, we're going to manage the physical needs for H&P, assess the level of consciousness, frequent vital signs, skin color, capillary refill, signs and symptoms of shock, abdomen, including distension, guarding, and peristalsis. Also, determine the history of the previous bleeds, blood transfusions, reactions, other illnesses or drugs that may contribute to bleeding, as well as their religious preferences that prohibit blood transfusions, such as Jehovah's Witnesses. Our nursing diagnoses would be impaired cardiac output, fluid imbalance, ineffective tissue perfusion, and anxiety. Other planning goals would include no further GI bleeding, identify and treat the cause, normal hemodynamic states, and minimum to no pain or anxiety. Our patient education would include avoiding GI toxic drugs like NSAIDs and corticosteroids, avoiding gastric irritants like smoking, alcohol, and other over-the-counter meds, testing for occult blood and reporting any positives to the provider, and in the case of varices, avoiding pressure, including severe coughing or sneezing. Also, blood dyscrasias, teach about the diseases, drugs, and the risk of GI bleeding. For emergency management, we're going to assess and monitor the circulation, airway, and breathing. Make sure we've got 2 large bore IV accesses, providing for both fluids, PPIs, blood, and also oxygen to go along with ECG monitoring, vital signs, and frequently assessing the patient's level of consciousness and identifying early any changes there. Labs, NG tubes, abdomen, bowel sounds, and making sure the patient is MPO. In the case of older adults, make sure we're also closely watching for fluid overload. For NG tube management, we're going to lavage 50 to 100 milliliters of it distilled and drained. We're also going to assess the stool and vomitus for blood, providing for oral intake, make sure we're monitoring any nausea and vomiting. This patient will be on clear liquids that we advance as tolerated. In the ambulatory setting, we want to avoid future bleeding and what to do if it occurs. Only take prescribed drugs, smoking and alcohol cessation resources provided as needed, and also any long-term care and follow-up that may be necessary. Outcomes would be no upper GI bleeding, normal fluid volume, normal hemodynamic state, and understanding of the potential etiologic factors and making appropriate lifestyle modifications. Finally, foodborne illnesses. Food poisoning takes many GI symptoms, including nausea, vomiting, diarrhea, cramping abdominal pain due to eating or drinking contaminated foods or liquids. There are over 250 illnesses, most due to bacteria during the growing, harvesting, processing, storing, shipping, or final preparation of the food. For our acute care, we want to correct fluid and electrolyte imbalances, monitor the CNS, especially with botulism, and in the case of E. coli, This is a toxin that can cause hemorrhagic colitis, as well as kidney failure, and should be considered life-threatening. Anyway, that's all we got for this chapter. I'll see you in the next slides.